Okay, let's see here. Okay. All right, everyone. I'm going to try to do this. I still can't get WebEx to work, which is annoying. All right, so I'm going to have to do this on Zoom, and then what we'll do is it will not close caption it. So I'll have to figure out something with WebEx. Apparently I have to schedule it into the future. So I will figure that out. But for right now, I want to get through a couple things for your first exam. So I put the exams in Blackboard with a range. So that'll be the week of. So for each exam, I'll give you guys at least 5 days to do it. So in case you're working or whatever, you can do them asynchronously, AM, PM, weekend. I'd like to incorporate weekends for everyone. So I generally like to do Friday through Sunday, or we can do Thursday through Sunday in case you need to schedule an exam or something in through the weekend. So I'm going to share my screen and go over chapter 2 on inflammation. It's super important that we go through inflammation because it's going to be part of any process, regardless of what the causative agent is. So whether it's a burn, a bite, gunshot wound, car accident, trauma, contusion, whatever it is. Your body doesn't know exactly what it is immediately, but it does know to start the inflammatory process. All right, so let me do a share screen, and hopefully I can get, oh, good Lord, of course not. Okay, share. Yeah, this might work. Okay. All right, we're in. Good. Get this stuff out of the way. Sorry guys, I'm on my MacBook. My ThinkPad does not have a video camera, so that's the issue we have. I can just figure out how to move this out of the way. All right, maybe if I just do this. Okay, this is beyond annoying right now. Okay. All right, so I went through this too, and the video, embedded videos will not play on my MacBook. They play on the ThinkPad. So if you're doing something on a, yeah, if you're doing something on anything other than a Mac product, they should work, but I have embedded the videos into Blackboard for you. Unfortunately, this semester, you guys are not in class, so we can't really go through this and do some question and answers. But if you want, please get a hold of me. We can do virtual office hours in case you have any questions. I know this is probably new to everyone. It's new to me. And like I said before, I think I mentioned they shortened the semester. So we're literally done May 5th. So there's no breaks. So, you know, it may be problematic if you have kids and you're on spring break, or different school districts have different things going on. So I totally understand. If things come up, just let me know. We're completely flexible. Hopefully we'll be going into a high flex model at some point, which will be live in classroom. You can come if you want. If you can't, we can do some Zoom and stuff, but we are working on that. So that's the thing. So I'm going to kind of walk through this. I don't have my thing I plug in that I can scribble on. I have this antidote thing up here, but it doesn't really work. So we're going to cell reproduction and differentiation. So it's important because if you have a problem with a cell or a damaged area, there's certain parts of your body, depending whether it's the ectoderm, mesoderm, what portion of the body, it can start regenerating. All right, and we're going to find out that some of these cells regenerate very, very often. So need your epithelial cells. They reproduce very, very often because they're used to abrasion, things sloughing off, digestive system, skin, hair, things like that. Other parts of your organ system, from the mesoderm, like liver, liver, kidneys have some regenerative properties, but some of your organs, they are designed to reproduce, but they're not designed to reproduce continuously. So if there's a disease process or inflammation or an infection, they can reproduce, but they're not, they wouldn't have as many stem cells available to do that. So we'll get all cells arise from the zygote. So zygote will be your first 8 cells after conception. The thing about a zygote is any one of those cells can literally turn into any portion of your body. So after the zygote, after those first 8 cells, as it divides more, those cells will produce stem cells, but they won't have a free palette to reproduce anything they want. They're going to be a little bit more specific, or they're going to differentiate a little bit more than a zygote. So stem cells form other types of cells, and some stem cells persist into adulthood. Sorry. So you probably learned also that some areas of your body can never regenerate. Like if we're talking about myocardium, skeletal muscle, central nervous system, they generally can't. Some books will tell you they can't, but there is research now saying there are stem cells, there's just not a lot of them. And we're talking about central nervous system, some of the supportive glial cells and astrocytes and things, they can regenerate, and they can cause other cells to regenerate to some degree. All right, so there's research on that. But for right now, I'm going to say no on that. All right, so please realize that you do have some cells that can regenerate. And remember, your zygote is your first 8 cells, and they can turn into anything they want. All right, all right, so this isn't a video, but it will not play in the MacBook. So, so here is mitosis, division of the nucleus. So I'm going to have to assume everyone has seen this before. If you're in level 200 course, you had this in either Human Bio Survey, ANP1, ANP2. So these are the stages of replication. We want to make sure that these replicate evenly. This is a regular cell. But remember, with a stem cell, they will generate their daughter cell, and that'll, if it's a zygote, it can differentiate depending on what it needs. It can differentiate into any type of cell. Remember, with those stem cells, they don't divide completely evenly. They have the regular cell and then the progenitor cell that turns into the stem cell. So they divide disproportionately, sort of like when yeast bud off. All right. So they always want to keep when the stem cell wants to make a daughter cell to differentiate into whatever it needs, but it always has to keep a copy of itself so it has the DNA or the information to reproduce, right? So I will be giving you a question on your first exam, which is basic dogma on mitosis. You know, what phase, telophase or anaphase or whatever the phase is, and what's going on during that phase. And remember too that the things that are missing in here are the G0 phase, where your cell or your immune system or your immune system or your body will check those cells to make sure that they're completely perfect. If they can send in protease or something to go in and check it, they will. If they can't, they'll destroy the cell. If it can be fixed, they'll fix it. If they can't, they just start all over again. So here, this is right out of your book. All right. So it's talking about different cells like labile cells, stable cells, and permanent cells. So labile cells, they're abundant stem cells. This is going to be the area where you're regenerating very, very often. So bone marrow, epidermis, gastrointestinal epithelium, because you have that food going through, it's going to start wearing off. Bronchial epithelium regenerates very, very often. So these are frequent reproduction. Remember here, it also says it's asymmetric division. All right, so you have a new libo parenchymal cell. Now, parenchymal, if that word I think was in chapter 1, parenchyma is a word they'll use. It means normal cell tissue. So normal parenchyma. If we're talking about heptic parenchymal cells, we're talking about liver cells. What they want normal. Parenchyma just means normal for that area. Right, so stable cells with long life, abundant stem cells, these are highly regenerative activity with injury. All right, so these are long life cells. So you think about liver, kidney, they shouldn't be regenerating continuously. All right, they have a job to do, and if they need to be regenerated, they will. So liver, let's see, you're taking some NSAIDs or some kind of medication, a lot of cardiac medication, and things like that can, cholesterol medication can really start damaging the liver. So the body's able to regenerate those, but it's not, it wouldn't be the normal for them to regenerate continuously. All right, liver has a lot of regenerative properties. Limitation matter. I mean, if you destroy 75% of your liver, the chances are it's not going to reproduce. But slow damage over a short period of time, it can regenerate. Kidney, same thing. Nephrotic things that can damage the kidney, a lot of medications, being Roundup glycosamate is very, very toxic to liver and kidney and your intestinal system. So under these nephrotoxins, a lot of medications, Tylenol, once again, cardiac medications, and some of these even immune depressants for people who have had organ transplants or bone marrow transplants. They can be very, very toxic for the nephrons too. So they can do that. Once again, it's asymmetric division. So we have the stem cell and the daughter cell, all right? And then permanent cells, no regeneration, is scarring only. So this is what you probably learned, like brain, central nervous system, heart, skeletal muscle. Once they're damaged, you only have a set amount of cells. And they say those are with you from life, from conception on. They usually, or they're going to say they don't regenerate. All right, so there is very few or no stem cells. There is research now. People have, there's cases where people have regenerated portions of their brain from a stroke, or they've regenerated portions of their heart, the myocardium that died. But generally, they're saying like, if these areas die, there's damage, the body will regenerate them with scar tissue. And obviously, scar tissue, or maybe not obviously to you yet, but any kind of scar tissue is not going to function properly. Like if the scar tissue, it's not going to, in the cortical region of the brain, it's not going to have the same properties as neural tissue or cardiac muscle. If you replace that with scar tissue, it's not going to have intercalated disc. It's not going to be able to propagate that signal through those specific gap junctions. Skeletal muscle, but scar tissue, it can't contract, all right? So there's going to be no sarcolemma, there's going to be no calcium running through that, there's going to be no cross-bridge theory. It's not going to happen with these type of cells, right? So here's just a chart. Your book's pretty good. It goes through a flow chart, so you can kind of figure out, this is what's going to happen, and there's always going to be exceptions. So don't think it's always going to be that way, but cell injury or stress. So if we have cell injury, we want to regenerate it. If there's stress, we want to maybe, a normal case would be a callus, or let's say a woman is gravid or pregnant. If there's stress or something going on, they're going to regenerate. Normally, they're going to regenerate or increase the number of cells. So it's a callus, we're going to generate more cells on the skin to form a callus. If it's female, we're going to produce more lac, lactate, yeah, lactate producing cells, milk for the child. Minor injury or stress. If it's acute, remember with acute, that's sudden damage. So your body's going to have a very, very quick reactive process to that with inflammation. And if hydropic or fatty change, hydropic change, we'll talk about that, is when we have damage to the cell or the area and that the cells can't get oxygen or nutrients. They can't run the sodium potassium pumps. So what happens is the sodium stays inside the cell. And as you know, fluid from the outside goes into the cell and the cell becomes larger or it has more fluid in it. And sometimes they can burst or die if we can't get those sodium potassium pumps up and running right away. Now, chronic injury is something that's happening over time or it's happened for a long period of time. And usually with chronic injury or stress, the symptomatology is generally not as severe, and how do I phrase this? The inflammatory or reproductive phase isn't as drastic as something that's acute and immediate. So intracellular accumulations, we have fat, cholesterol, protein, glycogen, pigments, and like lipofusion. If you see that in a cell, if we were in microbiology or in and you looked at a cell or we had you looking at some kind of slides and you saw these little spots, say, well, that looks like lipofusion. All right, so those are really like they're like age spots. All right, so we could say, well, if this cell has lipofusion in it, those are accumulations over time. So that cell is probably not young or newly developed. So we can have adaptations, accumulations over time here with chronic injury, or chronic injury over time. The body has to adapt, survive or perish, right? Or adapt or perish. So we have atrophy, and we'll go over those terms. It's in your book. So if we're not using that area, it will atrophy. Your body's not going to keep producing energy to keep something alive, and yeah, it's not going to keep it around if it has no use for it. It's going to be a waste of resources, right? Hypertrophy, hyperplasia, metaplasia, dysplasia. We talked, or we didn't, we weren't in class. So metaplasia is where your body is going to give you some type of different tissue as a survival mechanism. So generally, instead of something columnar or cuboidal, it's going to start laying down squamous layers for protection. There's something irritating it continuously. And then obviously, or maybe not obviously, relief of injury or stress. Once it goes away, if it's something temporary, you should have reversion to normal. All right. If it's severe injury and your body can't fix it, then you're going to have necrosis or dead tissue, pathology, or death of the cells. Right. So cell injury, disease, and death. Cells can be injured in several ways. And once I said before, it matters not to the body at that point what the damage is. All they know is from the release of chemicals or cytokines or chemical chemotaxis, release of chemicals in damaged tissue. The body's just saying, listen, something is damaged. We don't know what it is immediately, so let's just start the inflammatory process. We'll figure it out in a minute. So cells can be injured in several ways. Anoxia, right, that's no oxygen at all. A always means no or none. Hypoxia, low oxygen. Ischemia, all right, and those terms can get mixed up. Hypoxia just means low levels of oxygen. Ischemia generally means that there's no blood going to the area, which can cause hypoxia. All right, so be careful of those terms. They're interrelated, and sometimes they're used incorrectly. All right, can lead to hydropic change due to the lack of oxygen, ATP for sodium potassium pump operation. So, like I mentioned before, we see hydropic change. That means that we couldn't get oxygen to the tissue. It might just be, maybe there's a problem with the respiratory system. They couldn't get enough oxygen in, maybe they had pneumonia or something else going on, or the respiratory system was working generally very well, except we couldn't get blood, couldn't get delivery, couldn't get a delivery truck to the area. So really, the cell doesn't know. It just knows that there's no oxygen coming out of the capillaries into the interstitial tissue to get into the cells to run the Krebs cycle. So it knows it can't produce energy, it can't run the sodium potassium pumps. And then, as probably remember, so if we gave you a picture of a cell, would have 2 potassiums inside, 3 sodiums outside. That's kind of the general central dogma picture of it. And we always, we know the sodium potassium pumps run that cyclic motion. But if we have too many sodiums inside the cell, once again, water always follows sodium. There's no exception to that I know of. So we know that water follows sodium. The cell is going to become well enlarged. It's going to have too much fluid inside of it. Let's just leave it at that. So physical, chemical, radiation, toxins, microbes, inflammation and immune reactions, nutrition, deficit usually, genetic or metabolic or aging. So these are all ways that we could injure cells, or these would be perfect situations for the cell, all right? So any of these things can cause inflammation, all right? Like I said, it matters not what's causing it. The body just says, well, these are some of the things that could cause irritation or inflammation. And inflammation is your body's immediate response to any kind of injurious chemical or method. It's just its way of fixing it immediately. It's its immediate response. Mild injury stress causes reversible cell change. So if it's mild, even if we're talking about denaturing proteins or something, or breaking hydrogen bonds with nucleotides or something, if it's minor and we get it in time, we generally can fix that, right? So atrophy, hypertrophy, hyperplasia, metaplasia, or dysplasia. If the injury is mild, the body generally is very, very adaptive. I mean, we're going to realize, or hopefully you guys will realize, how absolutely incredible the human body is. It can actually, it can regenerate itself if you give it a chance and you're eating healthy and you're taking care of yourself. You're not dousing yourself with chemicals or pesticides or genetically modified food, alcohol, tobacco products, or whatever. Your body can regenerate itself if you give it a chance, right? Now, if we have severe injury or stress causes cell death. So apoptosis, so that's programmed cell death. So, or necrosis is dead tissue. Apoptosis, we can talk about that for half a second here. We're talking about any kind of virus. I mean, in the current situation, if you have a virus that has entered your cell and it's replicating, so it got past your innate immune system, it got past all of your defenses, and it literally attached to your MHC1 markers on your cell, and it actually gained access to your cell, and it's reproducing in there. Your body will give off interferon, or cells in the area, if they've been invaded, will send out a chemical signal and cause those cells to say, listen, if you're infected with this particle, this viral particle from whatever the virus is, we want you to perform apoptosis. We want you to kill yourself so that you don't turn into a virus-producing factory. Right? We'll talk about that throughout this semester. So normal defenses in preventing disease. So here's, kind of what we'll talk more about this with the immune system, right? So it's very important that we realize we have a mechanical barrier. Skin or mucosal membrane blocks entry of foreign invasion. So your skin should block that, and in any of your mucosal membranes, any part of your body that's outside of your body. So that's going to be your respiratory system, your digestive system, your reproductive system, and your urinary system. All right, so start getting into your mind that that's literally outside your body. It's where the outside environment is exposed Your body's exposed to the outside environment. All right, any of those linings will have IgA, immunoglobulin A, and they should be opsonizing or binding or contacting any kind of foreign material and marking it for your immune system. All right, so there's arguments out there about coronavirus viruses and the mask. So they're saying, well, you know what? Take the mask off, let the viral particles breathe them in, the turbines of your, yeah, those tortuous chambers inside your nose that have the mucous membranes. They're saying, well, let those attach to that. Let the IgA attach to it. Let's get some oxygen burst, hydrogen peroxide. Our body has these lysosomes and things that they can attack this and, let your dendritic cells grab these things and make antibodies to it naturally rather than going through the virus. I'm not saying these are right or wrong. I'm just saying there's other theories out there, or some people are thinking those things. But anyway, these are your normal defenses in preventing disease. So let's just say that we were back in the 1600s or 1700s or early 1800s where we didn't really have vaccines. These would be normal ways that your body would, if we had some kind of outbreak, and we've had several of them before. Coronaviruses are not new. Viruses are not new, but back in the day, if we had those things, these were how you'd have a mechanical barrier and you have these mucosal membranes. Your body was designed to have these kind of adaptations available. That's how your immune system will work, but we'll talk about that later. All right, saliva and tears are natural defenders due to antimicrobial properties of enzymes and chemicals. So your saliva has antimicrobials in it. Your tears literally have enzymes in them that can go in and they will break apart the peptidoglycan layer of a lot of these gram-positive bacteria. Very similar to penicillin. It'll start breaking apart your NAM and NAG units of your a lot of these bacteria that can be in your eye. So let's say you're wearing contacts, or you touch your eye, or you come across something toxic. If you have micro bacteria or something in your eye, we have some lysosomes in your tears that can start breaking that down. We'll leave it at that. That didn't turn it on. So phagocytosis. All right, so we all know that that is, part of your natural immune system, your innate immune system. So your body will go in, and we have monocytes that once they leave your blood turn into macrophages. And these are phagocytic cells that go in and they'll consume anything that looks foreign. Remember, your body has these molecular patterns. So one of these pathogens have very, very similar molecular patterns on their cell walls or their cell membrane. So if these macrophages look and they see a molecular pattern that they know is not theirs, they'll go in and attack it. They'll go in and consume it, destroy it, they'll digest it and release it. And if it's an antigen presenting cell, it will go in and consume these particles and it will present these antigens or molecular patterns or particles to your immune system and say, listen, I need to get an antibody to this. And we'll start antibody production, but we'll talk about that later. This is your second line defense along with inflammation. So initially inflammation, and we'll get into this in a minute. If something is foreign and you have an inflammatory process, what's going to happen is a lot of things your capillary beds are going to open up, and a lot of these monocytes will start leaving, they'll turn into macrophages. And we're going to have some liquid fluid from the capillary beds leaving, so we can bring in some kind of chemicals, so chemical gradients to bring in other cells coming in. We also, we might want to put some fluid into the interstitial tissue in that area to flush out. Let's just say you were bit by a spider or a bee, or God forbid a snake or something. We want to send fluid in there to dilute any kind of toxins. Maybe at this hymen, or arachnid or reptile had left into your system. So phagocytosis is a process in which foreign matter is engulfed and taken up by neutrophils and macrophages and destroyed. This is used on bacteria and foreign matter. And what we'll do, like I said, the neutrophils and macrophages go in, they destroy it, and they can process components of this to present to your immune system. Very similar to a vaccination. Vaccination, we're going to take the particles or part of a capsid of a virus or a component of a virus, and we're going to present it to your immune system in a way that the immune system will, it'll make antibodies to that specific portion. And so when it gets introduced to that material again, it'll automatically have the recipe for the antibody for it. In a simplistic way, I guess. Sorry. All right, so immune system, very specific third line of defense. This is your adaptive immune system. We'll get into that later on. So just kind of remember, we have our mechanical barrier, or skin, or mucous membrane is kind of your initial first line of defense. You know, we can get into later on, if we were in class, we would get into the the hand sanitizer. People are using it, and I realize if you're in a healthcare setting, you have to, obviously. But you have to remember there's alcohol in there, and there's hydrogen peroxide in there, glycerin, hopefully. But remember, you're also drying out your skin, causing cracks and crevices where things can get in, and you're starting to kind of breach that mechanical initial barrier. So our initial barrier, first line of defense is the mechanical barrier and your mucous membrane. Second line of defense is kind of once things get past that first line of defense, past your skin or mucous membrane, then you're in your body. So we kind of want the immune system to hype up, get ready. They're saying, well, there's foreign invaders, so let's send out some macrophages, neutrophils, and these only live, honestly, like 2 or 3 days. And they're going to fight and consume whatever it is and present these particles to your immune system so that we can hopefully start making antibodies to it. But if that fails, and we go into the very specific third line of defense, the adaptive immune system, and that'll be your T cells and B cells, and we'll go to that in a minute here too. Works through the stimulation or turning on of unique antibodies and sensitized lymphocytes. All right, CBC with differential. All right, so white blood cell count. So this is very, it's sort of informative. It's not exact, but if we order a CBC with differential, we want a complete blood count with differential. We want to know, like, what is your blood count. So if something is elevated or under, or if it's to the left or to the right, we want to figure out, well, what's going on. If we have elevated, sorry guys, I can barely, I need to get some water. We have elevated neutrophils. We're going to say, well, your neutrophils are elevated, so you probably have some kind of bacterial infection. If your eosinophils are elevated, we say, well, that's probably due to a parasitic infection or possibly allergic reaction. If your basophils are elevated, all right, that's usually allergic reaction, histamine, serotonin, and remember, your mast cells are related to your basophils. They're just kind of in your tissue. All right, they're in the periphery, but we'll get into that in a minute too. All right. So unfortunately, I do not have my sketch pad thing I can draw on. It's on my desk at school. So there's a video in here. So hydrostatic pressure and osmotic pressure. We're into the inflammatory process, but I kind of want you guys to start thinking about how your capillary beds actually work. And this is extremely important because I literally didn't fully understand this until I got to grad school, and I kind of figured it out on my own. And I thought to myself, well, why in the hell didn't someone teach me this before I got to grad school. All right. So what's the purpose of the capillaries and how do the capillaries work? Well, remember your capillaries are very, very tiny. There's only enough room in that lumen for one red blood cell. That's as thick as they get. And literally everything that happens in your body, all the exchanges in your interstitial fluid to your cells, every single cell in your body has to happen within the capillary bed. All right, so as things are leaving the capillary bed, you know, your amino acids, your carbohydrates, oxygens, a lot of your hormones or any of these chemical signals that we need to turn on or off cells, tell them to do something or not do something, are leaving your capillary beds. All right, and then after your cells have consumed the oxygen and run the Krebs cycle, they're going to release some carbon dioxide into the interstitial fluid, and a lot of the chemical waste your cells are going to release. Or if your cell is producing a protein or some kind of a chemical, it's going to, exocytose is going to leave the cell, and it has to get back into the capillary bed to be recirculated. So hydrostatic pressure is the pressure from the arterial end, where the pressure is higher, pushes things out of the capillary bed. And then as the cell uses it and releases it, it has to somehow get back into the capillary bed. And sometimes there's not enough actual pressure. So osmotic pressure is kind of, it's a protein that's in your blood, that stays in your blood, that kind of pulls it in. So just kind of think of like a compressed sponge, and as you release that sponge, it kind of pulls things into the capillary bed. But I've embedded a video in Blackboard what it'll show you. But please remember, it's extremely important when we start talking about the inflammatory process, that some of these inflammatory chemicals are going to cause the capillary bed, these cells to open up. All right, and then as your capillary bed's only one cell thick. All right. That's it. So these cells can open up, and as they open up, things can leave the capillary bed. All right. So let's just say even if it was a platelets, right? So you got you got caught, or there was injury to the area. We want the inflammatory process. But when you have platelets, which come from megakaryocytes leaving your capillary bed, remember, as blood or platelets leave your blood, the minute they leave your blood, they should start clotting. All right, so blood should never, there should never be intravascular coagulation. There's always, whenever blood comes in contact something that's not part of the capillary bed, so outside the capillary bed, or if it's hitting some kind of medical device, the minute the blood hits that, it says that's not normal, it's going to start clotting immediately. That's its job. All right, so normally capillary actions, movement of fluid, electrolytes, oxygen, and nutrients out of the capillary at the arterial end. That's the higher pressure. Remember, it's leaving the left ventricle at that super high pressure, and you know that's kind of what you're measuring with blood pressure. You're leaving like what is the pressure inside the ventricle to get it past that normal venous pressure that's in your blood system at all times. All right, so movement of electrolytes, oxygen, nutrients out of the capillary at the arterial end is based on the net hydrostatic pressure and the osmotic pressures inside the capillary bed. Right, so you can always think of it, you know, if you give me blood pressure 140 over 90 or whatever, slightly elevated according to whatever. So just, you got to remember that your left ventricle has to have a pressure of 140 milligrams of mercury pressure to get past that 90 milligrams of pressure that's pushing back on the semilunar valve there. Right? So the pressure has to overcome that to eject the blood out. But remember also with capillary action, we always have higher pressure on the arterial end. So in the capillary, it's always going to, that pressure is going to push the fluid out of the capillary bed, and then we have to be able to get it back into the capillary bed. And whatever doesn't make it quite back in there immediately, We'll talk about the lymphatic system and how that will, any superfluous fluid or whatever, we'll get back to the circulatory system via the lymphatic system. All right, so differences in concentrations of dissolved substances in blood and interstitial fluid promote diffusion of electrolytes, glucose, oxygen, other nutrients in the capillary membrane. All right, so what that literally means is things are leaving your capillary bed by a pressure gradient. It always goes from high to low. And I'm sure you learned that with osmotic pressure and everything. So the concentration gradients always, well, unless you're using active transport. So generally, they always go from high concentration to low. Right? So remember, it's always easier to go down the stairs from high to low than it is to go from the bottom of the stairs up. So always remember, it's always easier to go from high to low. So things are going to leave this. So if you have less oxygen outside of the capillary bed and the interstitial fluid, oxygen's always going to leave the capillary bed and go where the concentration gradient is lowest. Or if we're talking about oxygen, glucose, any other nutrients, it's always going to go from higher concentration in the capillary bed to lower. All right. And if you're building up carbon dioxide outside the cellular waste, it's always going to be higher in the interstitial fluid. It's going to go from high concentration in the interstitial fluid into the capillary bed because the concentration there is less. It always wants to even out that concentration gradient. That's kind of how it works, generally, not always, but generally that's how it works. So blood cells and plasma proteins normally remain inside the capillary. Right, so any kind of blood cell or plasma proteins, albumin, your immunoglobulins are also protein. IgA, IgM, IgG, those are all proteins. They want to stay inside the capillary bed. And you want that albumin inside the capillary bed because that's literally what's pulling things through osmotic pressure back into the capillary bed. All right. And like I said, watch the video. I will see if I can get the pad to work. It's just, it's very hard for me. I guess I could figure out a way to maybe record me doing this on a whiteboard to kind of show you, but the video does a pretty good job. I can't say it's not good. So venous end of the capillary, that. At the venous end of the capillary, where capillary hydrostatic pressure is decreased and osmotic pressure is relatively high, carbon dioxide and other waste return to the blood. Remember, you have that osmotic pressure or that protein. The protein is going to literally kind of pull a lot of those fluids and a lot of that stuff back into the capillary bed. And remember, it's going to, outside in the interstitial fluid, anything that's in high concentration there, it's going to be pulled back to the capillary bed because it's going to be lower in the capillary bed. So it's going to go from high to low. Excess fluid and any proteins are recovered from the interstitial area by the way of the lymphatic system and eventually return to the general circulation via the thoracic duct. So if you remember from A&P or human bio or whatever you took before this, the lymphatic system was always, they always probably do it in green. And these were closed-ended, one-way valves. And then remember, with the pressure in the interstitial fluid is high, it's going to open that valve up. The fluid's going to come in. When that pressure equalizes, the flap closes. Now, all that fluid in the lymphatic system is there until you move. And then, just like the veins, the pressure is going to move that towards, it's always moving towards the heart. And it's going to go to the thoracic duct on the left and the right subclavian, or thoracic duct on the left, yeah, the right subclavian on the right. All right, and then, get into the draining of the right head and neck and arm into the right thoracic duct, but that's really out of the scope of this course at the moment. We'll talk about that. Yeah, so remember that movement, this fluid will be in the thoracic area and it'll be in the lymphatic system. And with movement, it pushes that fluid towards your heart. We want to recirculate that. Similar to if you had a professional massage done, they're always doing massage distal to proximal, always moving things in. So massage is we're relaxing the muscle tissues, but we're also kind of flushing out the lymphatic system. And they'll always tell you after a massage, you need to drink a lot of fluid because we have to increase that blood volume, and we're increasing that blood volume because we have to remember we're getting a lot of those toxins and things from the lymphatic system right back into the circulatory system. And we want to make sure we have enough volume there and increase some of that blood volume, increase the blood pressure to force the kidneys to produce more I guess we'll just call it urine at this point. It's not urine until it leaves, but to produce more filtrate. And then with the filtrate, if the kidneys are functioning properly, they're going to expel any toxins or anything that the body doesn't really need through urine. Okay. So the elements of the inflammatory process, right? So there's your arterial line. Remember, the pressure is higher here, all right? Here's the venous end. So as the pressure gets higher, these cells are going to open up. I remember I said they're only 1 cell thick. So increase pressure. All these things can leave the capillary bed and get, and this is all your interstitial fluid, and around here, let's see, this is going to be sketchy. So around here are all of your, good Lord, it's like an etch a sketch gone bad. It should be a different color. All right, this is bad. Can't even find it. I need my pad. So anyway, blood's going to be leaving, fluid's going to be leaving here. We're increasing the pressure. This is going to be your arterial line. Remember, this is your right arterial line. So things are going to be leaving here. All right. Interacting with the cells. The cells are going to use all this. Can I switch this to a different color? All right, so then as your cells use this, they're going to be excreting CO2. That's bad. That's really bad. And a lot of these waste products are going to go back into the bloodstream here. Remember, through that oncotic pressure or albumin, it's going to be pulling it back in. So it's pushing everything out here through hydrostatic pressure. It's pulling it back here through osmotic pressure, the protein, albumin, and so on. But remember, not all these fluids are going to return back here, not 100%. So whatever's left over is going to be, I'm going to try to draw a lymph node, and I got to picture this in green, if you will. I'll put the valve there, right? Your lymph node. This is going to be going to your lymph node and then back to your thoracic duct or whatever. So any of this extra fluid doesn't get pulled in here. As the pressure builds in here, all right, fluid's going to go in to the lymphatic duct there. When the pressure gets equal, all right, this valve's going to close, all right, and then as you start applying pressure to this lymphatic system through movement or, what, breathing in the thoracic area or just any kind of muscle contraction, because remember, your arteries, veins, lymphatic systems, sometimes nerves, they all run together in these bundles. Right, it's going to be pushing all this fluid back into your thoracic system. Okay. Now, is it going to play? No. All right. So when this plays for you guys later, watch this one. It's actually pretty cool. Good graphics on that. It's going to kind of show you how things work in the bloodstream. So you get kind of an inside view from the actual, this is called the lumen. So whenever we're talking about lumen, it's going to be the inside of a hollow organ, whether it's a arterial, a venule, capillary, nephron, digestive tract, bronchial, anything. This is called the lumen. All right. So when you use that word, and when you start thinking the area within some kind of hollow structure, I don't care what it is, urethra, ureter, whatever it happens to be. So inflammation is a normal body defense mechanism intended to remove the injurious agent, whatever it may be. So examples, like I said, could be a sliver, could be hell, it could be you step on a nail or step on a piece of glass, could be a bite, whatever it is. We want to remove the injurious agent. So whether it's through phagocytosis, if it's bacteria or a virus or um, prion or something, we want to be able to remove that. Can be seen with a cut, allergic reaction, insect bite, infection, or small burn on the body. So even if it's you get a blister, you touch something something hot on the stove or the oven, or even if you burn your mouth on pizza or chicken wing or whatever, something hot that you bite into, your body doesn't know what happened. It just knows I need to send the inflammatory process because I have damage. All right. So what can we do to fix that before the tissue gets destroyed? The signs and symptoms of inflammation serve as a warning of a problem, which may be hidden within the body. So remember, if we didn't have these pain-sensitive corpuscles and things in the nervous system, we wouldn't know there was damage. We wouldn't be able to send the inflammatory process. Remember, any of these injurious agents are going to start destroying cells. All right, so that's how it kind of works simplistically. If you destroy a cell, literally what happens is the cytoplasm, the inside area of that cell, the cell wall breaks. The cytoplasm inside the cell gets released into the interstitial fluid. This is going to happen with hundreds or thousands of cells, depending on the damage. So when the interstitial fluid has all of these contents of the cytoplasm in there, the body says, wait a minute, these internal components of a cell should not be in the interstitial fluid. So it says, you know what, something's going on. We need to send the inflammatory process in to figure out what's going on, because there's cell damage here. We can tell because there's, just think of, like, if you looked outside your window of your house or whatever, and there was a bunch of garbage or something outside of your house that didn't belong there, you would say, well, wait, something's going on. We need to figure out what's going on. So it's kind of what your body's saying. It's saying, well, there's all this internal cytoplasm of a cell outside of my cell in my interstitial fluid. We need to send something. So there's the capillary bed in that area, that vector. It's picking up this signal. We need to send monocytes or neutrophils or something to the area and figure out what's going on. All right, and we'll get into some of these signs and symptoms that you guys are probably familiar with. So here's some areas of tissue injury: hypoxia. Remember, so that's decreased amount of oxygen. So it could be from ischemia, which would be a block in the blood stream somewhere, capillary bed or whatever. Infarction, so we had myocardial infarction. So we had hypoxia, maybe ischemia of the heart, myocardium, didn't get enough oxygen. Those cells died. Now we have a major problem. We have dead cardiac tissue, myocardium, that can only be repaired with scar tissue. So now we're going to have a problem with the pump. The pump is not going to be running at 100% efficiency. So from now on, we're going to have a problem getting the blood either into the respiratory system through the left or the right ventricle, or we could have a problem with the left ventricle, which is most common. Now we're going to have a systemic problem because the left ventricle is going to be pumping the blood systemically through the body. So if that's injured, we're going to have a problem getting that. We'll really talk about that with the cardiac system. And that's going to start affecting the respiratory system, which will start affecting the urinary system. And we'll talk about that in some detail. Direct physical action. So could be contusion, ecchymosis, a bruising, could be fracture, ionizing radiation. So ionizing radiation, using ionizing either UV or massive amounts of X-rays or imaging. So ionizing, when you talk about ionizing, remember it's going to be ions have either a positive charge or a negative charge. So if you're using ionizing radiation, you're hitting these cells or this area with ionizing radiation. And what it literally does is going to be splitting water. So you have water gets literally split. So we have H plus on one side and OH negative on the other. All right. And the negative OH on, yeah, that starts pulling things, attaching to the ends of the DNA. And we'll start talking about DNA strands, the OH strand, you have a 5' and the OH, 1', 5', OH on one end, H on the other, and you have the DNA strands. It starts really destroying the replication of the cell because you really start messing up the configuration of the DNA. All right, infection. All right, so infection could be, a lot of different things. So could be bacterial infection or whatever something is, and if it's, hopefully it's local. If it becomes systemic, then it runs, these bacteria or whatever are going to start reproducing inside the bloodstream. Immune injury, nutritional deficit or excess. Genetic defect, there's some defects, we might not be able to do some enzymes that can break things away, CTAX or Tay-Sachs and some other different genetic problems that we have. Toxic molecular injury, production of cell-derived and plasma-derived inflammatory mediator molecules. All right, so we're just saying, these are the injured tissue. We talked about that. So if the cytoplasm of that cell is being released into the interstitial fluid, that's going to trigger production of cell-derived or plasma-derived inflammatory mediator molecules. So the bodies know there's something wrong, it's going to start sending things through the capillary bed, through the bloodstream to the area. All right. So mediators induce vascular reactions. So we're going to send some cell-derived or plasma-derived chemicals to the area. Histamine, you've heard of that, or antihistamine, serotonin or arachidonic acid from the cell membrane, increases pain, nitric oxide, kinin, complementary and coagulation factor. So we want the blood to coagulate. We have complement, and you probably learned that with the immune system. We're going to have a cascade of events that can help repair injury. All right, so at this point, it doesn't really matter. We're going to cause vasodilation. So what happens initially, that lumen is going to dilate. That smooth muscle is going to relax, all right, and allow that lumen to increase. So as it increases, we can get more blood volume through that lumen. All right, but remember, with more blood volume, we have more space. So generally, the blood slows down. And remember, in the middle of the lumen is where the blood's going to go the fastest, right? In the middle. It's kind of like a river. The river always flows faster in the middle. Towards the edge, it gets slower. All right, so hopefully we do vasodilation. So everything in the middle flows really, really fast. So that would be like the plasma. A lot of these heavier components, like your white blood cells, let's just call them white blood cells or red blood cells. They kind of move out to the edges where it's lower because they're big and heavy and clunky. All right, and then we know that if the cells move to the outside of the lumen, and then we can get the capillary beds to open up, any of those components can leave the capillary bed and go to the interstitial fluid. Right? So increased vascular permeability causes edema, and edema is generally fluid that leaves the capillary bed and goes to the interstitial fluid. So edema is going to cause that swelling, or if it's a bite or something, it's going to flush out those tissues. It's very, very important, right? So mediators attract leukocytes. Leuko means white, cytes means grown cells. All right, so leukocytes, these are going to be your white blood cells. Right? And I'm sure you guys learned like your neutrophils, basophils, all those different types of cells and what they do, hopefully, and if not, we'll review it. All right, so neutrophils, platelets, and mast cells. So if it's acute, it's quick. Neutrophils are going to be Elevated with bacterial infections, generally they're a little bit smaller. Their job really is, they're the first responders. Their job is really to fight bacterial infections. They can be phagocytic if they have to. They'll go in and destroy. They can sometimes be antigen presenting cells. They'll go in and destroy whatever it is, and they'll present particles of it to your immune system if they need to. It's not their primary job, but they can do that. Platelets for blood clotting. If we've injured tissue, we want that to clot. And then mast cells. I said these mast cells were the cousins of basophils. Basophils are elevated with allergic reactions. So mast cells are in your tissue. Generally, they're in your tissue and specifically around mucous membranes. So if anything is in the area that can cause an immune or allergic reaction, they'll start releasing histamine and serotonin and all kinds of things. And if you have a lot of itching or swelling, you take an antihistamine to sort of subdue the reaction of a mast cell. Then you have chronic inflammation. That's something that's been going on for more than 6 months. Generally, that's a technical. Could be 3 to 6 months, or it could be semi-acute or semi-chronic. There's all different components in terms for this. They're going to release macrophages, right? Those are from monocytes, lymphocytes. All right, so your lymphocytes, remember, these are your B cells and your T cells. So now we're going to hit the adaptive immune system, because this is not acute. This has been going on for a long period of time. So once you start hitting, not sequestering, if you start recruiting B cells and T cells, this is usually been going on for a long period of time. Now you're going to make antibodies through plasma cells and T cells, could be CD4 or CD8 killer cells, or we can actually start recruiting natural killer cells and things. We'll get into that, the immune system. And then plasma cells, once again, plasma cells are derived from B cells, but plasma cells specifically make antibodies. Inflammation is the body's non-specific response to tissue injury resulting in redness, swelling, warmth, pain, and perhaps loss of function. So when you start talking about inflammation, all right, so this is the beginning of pathophysiology, all right? So inflammation is always going to be what are those cardinal signs? And if I say, well, somebody has an inflammatory process, well, what does that mean? Well, you could say, well, they have, could be redness, swelling, pain. I say that's great. Well, what's causing the redness? What's causing the swelling? What's causing the pain? Right? Disorders are named using the ending itis for inflammation. So tendinitis, pancreatitis, laryngitis. So whenever you see itis, that's inflammation. So if somebody has an inflammatory process, we're not saying they have a disease. We're just saying something in that area started damaging or disrupting that tissue. So the body is going in and sending the inflammatory process in an attempt to fix it, right? And hopefully, inflammatory process will be enough to fix it. We don't have to go into a pathology or disease, or we want to stop the process whenever we can at that point. So associated with many different types of tissue injury, it can be direct, such as cuts or sprains. All right, so cuts or lacerations. So sprains, so we're going to learn too the difference between sprain and strain. All right, so we're going to learn that too. Right. So, if you're straining to do something using muscle, so a strain generally has to do with tendon to a muscle through those Sharpie's fibers where they attach to the, what's that called? Lord. I'm brain dead right now. Sharpest fiber attached to the periosteum. Sorry. Yeah, the periosteum. All right. All right. So a sprain, though, is when you have bones attached by ligaments. All right. And then once you sprain something, right? Once you take that ligament, you stretch it out. Generally, they don't really like to recoil back to their original shape. So once you sprain something like an ankle or a ligament, generally it's always a little bit, ligament laxity is what we kind of learned in graduate school. So once you have ligament laxity, these things generally never quite go back to the way they were. But unless you're talking about somebody had a fall or something, or you're talking about if you're working with the athletic population, you'll see a lot of that. So chemicals such as acids or basic solutions like lye, remember, they're going to really alter the pH. So something acidic is going to have a lot more hydrogen ions. Something base is going to have a lot more hydroxyl negative OH ions. And either of these things can start destroying a chemical environment, and cells will start dying, or they can be denatured. And if you catch them in time, something that's been denatured, if it's not completely denatured, if we haven't changed the tertiary or quaternary structure of something, you can generally, it will reconstruct itself. I would like to think, right? So ischemia, cell necrosis, or infarction. So we're losing blood or oxygen to the area. So we have the hydropic change. We have this sodium potassium pumps can't work real well. Now this is an immediate response. So after that, after a while, these cells are going to burst, or they're going to start to, they could crenate too, I guess, theoretically. All right. Or if we have a problem with the external environment, these cells will not be able to, an ability to thrive or to live. All right. Allergic reactions or physical burns. All right. You do that. Foreign bodies, splinters, and infections. Anything foreign can cause it. So what's the pathophysiology behind this? Progress is generally the same regardless of the cause. All right. So like I said, your body doesn't know exactly what it is immediately. It just knows that there's something foreign in the area. And if it's a cut, sting, whatever it is, you're killing these cells, and their cytoplasm is being released into the interstitial fluid. So immediately the body doesn't know what it is. It just knows that that area doesn't belong. So it's going to send in all of these things to assess the situation. All right. So timing may vary with causative agent. Can be immediate with short duration, or have delayed onset, or maybe more severe with longer duration. Right. So it depends. If you have an injurious agent that's only there for a second, the damage won't be as much. But if you have an injurious agent that's there for a long period of time, let's just say it's a gunshot wound, or you had a laceration, and whatever lacerated is still inside the body, or with that you brought a ball of bacteria, or it's God forbid you're in a car accident or something, and you're crushed somewhere, the causative agent's still there for a very long period of time. So the damage can be much more extensive. Right. And here's the, this is weird. There's a picture again, but just remember what's going to happen. These can be any of the causative agents. All right. That can be outside your bloodstream. And these are some of the resources your bloodstream can send out to assess the issue. Okay, so when there's tissue injury, so you're going to send in your mast cells or some of these other cells. Platelets release chemical mediators such as histamine. All right, it's going to cause your blood vessels to dilate. It's going to cause things to leave your bloodstream and usually that's allergic reaction sometimes too. We want to flush out whatever is in there. All right, serotonin can produce a lot of pain. All right, prostaglandin, like I said, this is arachidonic acid, comes from your cell membranes, can cause increase in pain, and that's how some of these NSAIDs work. They stop this whole prostaglandin arachidonic acid cascade. They can break that whole chain reaction. Lycotrienes into the interstitial fluid and blood. All right, these chemicals affect blood vessels and nerves in the damaged area. So these chemicals are going to affect the blood vessels and nerves in the area. So blood vessels, we're going to technically, initially, your blood vessels contract, all right? So there's damage, all right? And the reason is, and I'll ask you guys this probably later in the PowerPoint, we, if we're contracting, we want to stop the blood because we don't know if a person's missing a limb or we've hit a artery or vein. We just know there's damage in the area. We want to shut the blood off of the area so that we don't bleed out. Then once we realize it might be that we're not losing a whole lot of blood, the blood volume isn't decreasing rapidly, then we'll dilate. We'll say, okay, well, we're not going to lose blood, so let's dilate. Let's send some aid to the area via chemicals and the chemical gradient, mast cells, macrophages, or let's send it some proteins, coagulation factors, something that we need, all right? And remember, these items, I'm going to be getting ahead of myself, these items are in your blood already ready to go. They're just not activated. Because remember, we want these things in our system floating around, but unactive, so that when we release them, then they become active. We don't have time to make this stuff. We want it there already, and we can send it out as we need to. All right, these chemicals affect blood vessels and nerves in the damaged area. Cytokines serve as communicators in the tissue fluids, sending messages to lymphocytes and macrophages or the hypothalamus to induce fever. So we're going to send, cytokines are chemical messengers, right? So remember, your cells don't have Wi-Fi, they don't have texting capabilities. So the only way they can get information out there is through chemical messengers, all right? And we want to send messages to lymphocytes, all right? Lymphocytes, site always means a grown cell. These are your B cells and T cells. So we're saying, well, wait a minute. We've already got past the first line of defense, our mechanical barrier, and our macrophages may not have cleaned this up right away. So now we have to go right into the adaptive immune system because we've already compromised the first two lines of the innate immune system. All right, and the hypothalamus to induce fever. All right, so there's a lot of talk out there about, what's the temperature that, you would start causing cell change or cell damage. All right, so we, anything like 104, 105, we're gonna say, well, that's kind of borderline. Anything past that's gonna start causing cells to denature, all right, and we don't want our glial cells or our cortical cells to denature because we kind of know that the central nervous system is going to regenerate, right? So we don't want that to happen. But we kind of want to induce a fever rationally, because if you induce a fever, that if your temperature elevates, it also primes your metabolic rate to increase, all right? And as it increases your machinery or your metabolic rate to increase, you're also increasing the activity of your immune system. So it's really pretty critical that we do that. All right, histamines released immediately from granules and mast cells and exert their effects immediately. All right, so these mast cells, generally, they've already been exposed to whatever this allergic agent is previously, for the most part. They have these mast cells, they have granules, they have these little lysosomes or bubbles in their cells. So once they're activated, something lands on these cells and turns the switch on, right? It releases all of these histamine granules. It goes into your interstitial fluid, and it's going to cause your blood vessels or your capillaries in the area to expand completely, bringing more fluid in. So nerve reflexes at the site of injury cause immediate transit vasoconstriction. So I said, when you initially have the injury, your body's going to, as I said before, it's going to constrict these blood vessels immediately. So we have to be able to assess the area. We're going to bleed out. If not, then we say, okay, all right, there's no immediate chance of death immediately from bleeding out. So let's open up the blood vessels and get more supplies to the area. Right. So it'd be like if there was a huge car accident. We want to block traffic off of that, but once we realize it's safe, we want to open it back up and let things through the area. All right, to counter this action, the immediate release of chemical mediators results in local vasodilation, which increase blood flow to the area known as hyperemia. All right, so that word hyper means over or above, emia, blood. So we want to bring more blood to the area. Right? Capillary permeability also increases, allowing plasma proteins to shift into the interstitial space along with more fluid. All right, so we're going to cause those capillary beds to dilate, and we're going to open up those cells to allow more things to come out. All right, and like I said before, we want to dilute any toxins in that area. All right, so if it was a laceration, toxins could be anything. Could be, you know, if you were in a car accident and you were pierced with a piece of metal, or, you know, we could make up any scenario we want. Blood clotting is done to try to sequester the injury agent. Remember, if blood leaves your capillary bed, let's say, you know, when you're injuring tissue, there's always blood supply there because every cell has to get blood supply. So whenever you cut yourself or whatever, you're bleeding, that blood's going to clot because it's exposed to the air and it's not inside the capillary bed. There's not nitric oxide coating the endothelium. That blood is supposed to clot. If it doesn't clot when it leaves the capillary bed, you've got a bleeding disorder, Christmas factor, or you could have factor 7, or you could have a major bleeding disorder, which is not good. All right, so leukocytes attract to the area of infection. Remember, leukocytes are white. So these are white blood cells. As damaged cells release their contents, several chemical mediators at the site of injury attract immune cells to the area. Leukocytes, all right, white blood cells. Macrophages and monocytes. Remember, macrophages are monocytes that leave the bloodstream. They turn into macrophages. These macro, big eaters, big appetite is what it means. These guys will eat, and they'll fight anything. They don't care what it is. They have no fear. They'll fight. They have voracious appetites. They migrate to the capillary bed into the interstitial area. They destroy and remove foreign material, microorganisms. This can be bacteria, viruses, and these things will even attack like parasitic worms, which are 50,000 times bigger than they are. They just start taking bites out of them. They're crazy. All right, and cell debris by phagocytosis and prepare the site for healing process. All right, so they go in and they clean up, they engulf everything, clean it up, the area. All right, when we get into chronic inflammation, some of these chronic diseases, this happens constantly. If you have a chronic irritation, like rheumatoid arthritis or something where your body's attacking itself, they keep sending in these macrophages to clean up the area. But as they clean up the area, and they're cleaning up everything around it too. So this chronic cleaning up can cause some major damage to the tissues in the surrounding area, but we'll talk about that too. All right, leukocytes are the cells of inflammation. Chemical signals mediate the inflammatory process. Remember, these are the chemical signals that are coming from the damaged tissue. The initial inflammatory response is vascular. The cellular reaction follows vascular reaction. Right? So diapoesis, if we didn't talk about that before, is movement of cells from the capillary beds. And when you watch the video, you'll actually see, they'll actually go through an animation where that capillary cells open up and these cells actually migrate out. Similar with platelets, megakaryocytes, they go in between the cell walls of the capillary bed and they leave. So diapoesis. All right, this P means feet, so they're like little feet. They move out. The cardinal signs of inflammation. All right, and this, I'm not sure if your book talks about this, but I wanted to bring it up. All right, so redness or warmth caused by increased blood flow into the damaged area. So if on an exam I said, well, you know, what causes the redness of the area? And you say, well, that's obvious, Dr. Well, it's because we're bringing more blood to the area, all right? Swelling and edema is caused by the shift of proteins and fluid into the interstitial space. Remember, the capillary beds are going to open up, that fluid's going to leave the capillary bed, and this is going to increase the volume in the area. It's going to cause swelling and edema in the area. Right, pain results from increased pressure of fluid on the nerves, especially in enclosed areas, or by local irritation of nerves by chemical mediators. All right, so if you have swelling, and anyone's had a swollen ankle, or if you damage your elbow or your wrist or whatever, all that swelling is going to cause compression because it's in a enclosed compartment. So it's pushing on those nerves, and you also have a decreased range of motion, if you notice. Like, you won't be able to move as much. Or as you damage the tissue, I said, all the cytoplasm leaves. The cytoplasm can actually start irritating the nerves. And remember, too, that only the nerves in your body can actually feel pain. There's no other area of your body. Your nervous system is the only system in your body that can feel pain. And also remember, when we're talking about the nervous system, or maybe you've already know this, but each one of your dendritic cells and nerve fibers, they're only sensitive to certain things. So one might be reactive to pain, one might be reactive to pressure, one might be reactive to heat, one might be reactive to cold, one might be reactive to light touch. So they can only read specific markers, or not your, each dendritic cell is only able to read very, very specific data. Right. Loss of function may develop if the cells lack nutrients, for example, liver cells, or if swelling interferes mechanically with an action like a joint movement, right, like I mentioned before. All right, exudates refers to things that leave the interstitial fluid formed in the inflamed area. The characteristics of exudate vary with the trauma. All right, so there's different types, and your book does talk about this. There's serous or water. Exudates consist primarily of fluids with small amounts of proteins and white blood cells. All right, so it's commonly seen in allergic reactions. So allergic reaction could be, you could have a lot of tearing, some swelling in the area, but it's not, if you push on it, it's not, the fluid is very serous or very water-like, or like a burn, like a blister. I'm sure all of us have popped a blister or whatever. It's just kind of like water. It's fluid. It's very serious, like, well, not serious, like SER, serious. It's very, very aqueous in composition, let's put it that way. So purulent exudate are thick, yellow-green in color, and contain more leukocytes and cell debris, as well as microorganisms. Typically, this type of exudate indicates bacterial infection, or exudate is often called pus. All right, so this is thick, yellow-green in color. And you could also say, like, if let's say you had say I really wasn't feeling well, and if your parents or whatever are nurse, NP, doctor, whatever, they'll want you to describe it, right? So whenever I had a cold, mom would say, well, what do you, what's coming out? Is it very watery, or is it thick green, yellow? All right, so if you were coughing up something that was thick, green or yellow, the exudate, knew that was a bacterial infection. If it was very serious, it was viral. All right, but we're talking here if it's a infection or something that's enclosed. So if it's purulent exudate, if someone's saying, well, there's an infective agent, what does it look like? All right, so that would lean us towards what's going on, whether it was very serious, aqueous in composition, or for thicker and had pus. And we've all heard the word pus or abscess or whatever. An abscess is a localized pocket of purulent exudate or pus in a solid tissue. Example would be a tooth or brain. So, someone will say, I have to go to the dentist, I have a tooth infection or whatever. So they'll describe it as an abscess. You have an abscess or an abscess in the brain. So you have an infection in your brain, that's a problem because you have an abscess. It's going to start destroying the area, and you have exudate or pus in there. So hopefully we can clean it out somehow. The body will clean it out, but it has to be replaced with scar tissue. You don't want to sit around and have something cleaned out. You want to have a hole in your head, literally, right? So you want that replaced with some kind of tissue. So hemorrhagic exudate may be seen if blood vessels have been damaged. All right, so hemorrhagic is going to be something contain more of blood exudate. All right, systemic effects of inflammation could be mild fever, malaise, and we talked about that term before. It was in your terminology. Fatigue, headache, or anorexia, loss of appetite. And we may have all experienced that. Fever or pyrexia. All right, remember Pyrex, the dishes, you can literally put them in the oven unaffected by heat or temperature. As common if inflammation is extensive, more severe if inflammation is due to infection, is contingent on the causative agent. And we talked about this a minute ago, or I babbled on about it. You know, there's different theories behind it. You want that fever to elevate a little bit to the safe zone. Obviously, when it comes 100, 104, 105, you want to, get that down immediately. So that might involve cold shower, ice bath, or whatever it takes to get that down low enough so you're not denaturing some proteins. So fever can be beneficial if it imparts the growth and reproduction of pathologic organism. All right, so if we were taking micro, we'll be talking about that. So some of these microbes only have a niche temperature that they can live in, or a certain range. So if we elevate that temperature, the microbe will not be able to reproduce as rapidly. And remember, if we increase our temperature as humans, we increase our metabolic rate, and we tell the immune system, listen, guys, we're on high alert, pay attention, we're going to need you to come in strong, let's ramp up everything. Fever is induced due to the release of pyrogens. That should be from white blood cells. These pyrogens circulate in the blood and cause the body temperature control system and the hypothalamus to reset at a higher temperature. So we have all these fever-reducing pyrogens, or these are chemical signals from white blood cells. Once they're activated, it's telling the body, elevate your blood temperature. We want to decrease reproduction of microbes, and we want to increase the immune system activity. And then we set the hypothalamus to a higher thermostat, to a higher temperature. Once the causative agent leaves, we should be able to dial down the temperature and bring it back to normal. Right. We can talk about, fever, shivering, people under a blanket shivering, producing excess heat. All right, shivering, here it is, can cause increased heat production. Vasoconstriction of surface capillaries helps to reduce heat loss from skin surface, all right? So we want to shunt the blood from the external skin, because that surface area heat can dissipate off that. We want to keep all that heat inside the body. We don't want to lose that heat. Right. Curling up is an involuntary action in an attempt to reduce heat loss. These mechanisms continue until the body reaches a new higher temperature. Following removal of the cause, the body temperature should return to the original setting by reversal of the process. That's how it should work. Right. All right, so diagnostic tests. Let's just say we have something going on. All right, so we're, if I ordered a CBC with differential, I want blood work. I want to figure out, well, what's going on? What can this tell me? Blood sample taken to do a complete blood count with differential, used to help determine the causative agent. Right, so like I said before, if the neutrophils are elevated, eosinophils, mast cells, lymphocytes, and then if we had a shift to the left, let's just say we had neutrophils, and if they said, well, they're shifted to the left. So now I have a whole bunch of white blood cells reproducing, but they're shifted to the left, which means they're not reaching adulthood. They're not they're plastic cells. They're not full-grown cells. I could say, well, wait a minute, they're elevated, they're immature. It's probably cancer. It's probably going to be some type of early stage leukemia, I would say at this point. It used to help determine the causative agent. Obviously I couldn't diagnose this, but the way my head would be going towards. All right, cell enzymes and isoenzymes are going to be elevated in blood in the presence of severe inflammation necrosis. So we're saying we're doing CBC with differential, but we want to look for certain markers. So I said before, if something's damaged, right? The cytoplasm of that cell is going to be released into the interstitial area or milieu, right? So if I did, and those things from the concentration gradient, I said they're going to go into the bloodstream. So if I had specific components, let's just say that I had a component of myocardial tissue that was showing up in blood work, I would say, well, wait a minute. That enzyme is only in cardiac tissue. So why is it in the blood? Well, if it's in the blood, that means that tissue, a lot of that tissue died. The cytoplasm or those enzymes that were inside of those myocardial cells is in the environment. It's been reabsorbed by the bloodstream. Now it's showing up in the bloodstream. I can say, well, if that enzyme is elevated, if that's specific to liver, kidney, heart, or whatever, I could say, well, these enzymes are showing up. They're specific to a certain organ. I can pretty much say there's something going on in that organ. There's some kind of pathology, necrotic tissue going on in that organ. All right. Helpful in determining the site of necrotic cells that may have released the enzymes into the tissues or fluids of the body. Right. Some examples are very specific, and there's just a couple examples that you're going to see that are pretty common. They'll show up on NCLEX and things like that. So such as isoenzyme creatine kinase, when there's a myocardial component, alanine aminotransferase, ALT is specific for liver. And there's other enzymes that your book talks about, or some of these CK, some of these other enzymes are just elevated when there's inflammation. Erythrocyte sedimentation rate, or some of these things, they're just commonly elevated with general inflammation. Right? So we just say, well, we don't know what's going on, but your blood work is showing that we definitely have some inflammatory process going on. So we know something's damaged. We're going to do a little more blood work, maybe we can figure it out. Right? All right, so potential complications of infection may develop in an inflamed tissue because inflamed tissue is more easily penetratable by microorganisms. So if you inflame something, you have, I'm unmuted. Okay, I'm not muted. So if you have tissue that's inflamed, you have a lot more volume in there. You're stretching these tissues. They're very, very stretched, and they become much thinner. Things can penetrate these much easier. And we're not in micro, but like Staph aureus and some of these other organisms, they actually can release enzymes that will coagulase. They'll actually digest their way through areas. So and you have an inflammatory process. You're already increasing fluid. You're thinning out that barrier. These things can eat their way through even easier. So deep ulcers may result from severe prolonged inflammation due to erosion of tissue. All right, if you're getting into well, any kind of healthcare, if you're going to be in a hospital or nursing home situation, decubitus ulcers, or we talk about bed sores, or to see someone in the hospital last week, and they had these super fluffy or padded socks on because I guess from being in bed for so long that they had some bed sores. All right, so that's going to be a whole different ballgame where microbes can get in there super easy. Right. Perforation can be another complication. And so even if we're talking about diverticulitis or something in the digestive system, you get inflammation, diverticuli in there, swelling, and these things can burst, dumping the digestive contents into the peritoneal cavity, can be disastrous. So skeletal muscle spasms or strong contractions may be irritated by inflammation resulting from musculoskeletal injuries such as sprains, tendonitis, or fractures. So let's just say you have any one of these things: sprain, strain, tendonitis, fracture, and this, what happens, your body's going to reflexively contract, all right? That can literally pull things out of position. Right? So like if you fall or twist or whatever, you can have a problem with that area for months, if you don't get it fixed or stretched or massage, chiropractic, acupuncture, whatever it is. If you don't get those things addressed and you kind of ignore it and think, well, it's going to fix itself by doing nothing, then later on you can have, major issues. And if you don't believe me, you can go anywhere. Wegmans, Tops, Walmart, Target, whatever, and you can just look at some of the population. You'll see they're walking with an antalgic lean, or they're walking completely crooked or hunched over or whatever. These could be injuries. They had an inflammatory process initially. They never did anything about it, and they kind of grow into that, I don't want to say deformity, but they grow into that situation. All right, so chronic inflammation, usually more destructive damage than with acute inflammation. Generally more collagen is produced in the area, resulting in more scar tissue formation. So I'm sure you guys learned, or you should have learned, that initially, and at the end, there's going to be some videos, and I embedded them for wound healing and burns, things like that. Watch some videos on that and realize that there's more collagen. Collagen is a precursor for repair. And, if you know you're going to go in for some kind of elective surgery, one of the things that a lot of the naturopathic integrative medicine is saying right now is if you want to consume a non-lethal dose of natural vitamin C, not some ascorbic acid. All right, it's got to be a natural form of vitamin C, whether that's derived from strawberries or rose hips or something. Natural whole food form can reduce a lot of the scar tissue. Very, very significant studies on women going in for cesarean births, a reduction of a lot of the scarring, just increasing their vitamin C intake a month or so before surgery, right? Off-site, off topic, but all right, granulomas may form, which are small masses of cells with necrotic center and are covered by connective tissue. Can develop around a foreign object like a splinter as part of the immune system response to tuberculosis. And it's in your book. They'll talk about tubercles or tuberculosis. Tuberculosis has a mycotic acid coating around it, so your immune system, really your phagocytes, cannot really get to it. So they can't actually kill it. So what they do is they start putting layers of your immune system cells around it, all right, to sequester it, keep it from getting any further. Because tuberculosis generally will start in your lungs, and if they breach the lungs, they get into your blood supply. They go to your heart, to the left side of the heart, okay, and then they're going to recirculate through the body. They can get off anywhere they want. So we want to make sure we sequester that off. Right? So that's a granuloma. Granuloma is tissue. And what happens is a lot of times the whatever that tumor or the gone tubercle is, it'll start to die, or it'll die because we kind of sequester it. Then you get something called caseous necrosis, where it's a very cheesy configuration. One of my cadavers in grad school had, we took the lungs out and they were super, super heavy. And we cut them open and there literally was, and I swear to God, it looked like large curd cottage cheese inside these lungs. It was pretty, it was gross but interesting, right? So this is not in your book, but I just kind of thought, well, if you're going into healthcare, these are just some things that was from A couple other textbooks that I've read have this in there, so I thought we'll just throw it in there. So aspirin can be used as an anti-inflammatory medication and works by decreasing the production of prostaglandin synthesis at the site of inflammation. It also relieves pain and stops increased temperature component. So I said before, we talk about arachidonic acid and prostaglandins and how this is how some of these work. No, and we can talk about Tylenol, Motrin, whatever. So please realize sometimes you maybe don't want to, maybe you want to reduce the pain just maybe due to swelling, or you may not want to reduce the increase in temperature. That might be a good thing. I'm not saying yes or no, but at least consider the possibility that increasing the temperature might be a good thing. So side effects are possible. Reye syndrome in children. So you never give children aspirin. All right. Allergic reaction in some, stomach ulceration, bleeding in others can lead to anemia. So there's a lot of, probably not as much anymore, but back in the 70s, 80s, and maybe the 90s, you'd have a lot of elderly patients who would be taking a lot of aspirin for pain or arthritis or whatever. And not only is it a nephrotoxin and a hepatotoxin, but it also caused a lot of stomach ulcerations. And these people would bleed, have these small stomach ulcerations, and they would literally become anemic, right? Okay. Aspirin also thins blood and can interfere with blood clotting process and may not be used in some situations. Or, they'll say, well, you've had a stroke, so right now, they used to give you a small dose of aspirin every day to thin your blood. But then again, if you cut yourself or you bump into something, you're going to bruise easy, and you could, you bleed too much if you get cut. So these things have to be monitored. All right, acetaminophen or Tylenol decreases pain and fever, but does not diminish the inflammatory response. All right, and ibuprofen. All right, so there's reduced production of prostaglandins. That's how it works. It releases a lot of the pain. Non-steroidal anti-inflammatory drugs are used to treat many types of inflammatory conditions. All right, if you have an inflammatory condition that you're aware of, or it's chronic, you could use this to reduce some of it. Reduces pain, inflammation, and fever. Used for musculoskeletal and arthritic conditions. All right, side effects. Prolonged use of severe liver and kidney damage. All right, and I have a few patients who literally just take ibuprofen and Motrin like a Tic Tacs for, could be low back pain, it can be for migraines or whatever it is. And, I worry about, liver and kidney damage, severe weight gain because I can't really process a lot of stuff because their kidneys and liver are not doing well. Glucocorticoids. So, some of these anti-inflammatory glucocorticoids are anti-inflammatory drugs, synthetic chemicals that related and mimic the action of naturally occurring glucocorticoids, which are hormones produced by the adrenal cortex gland in the body. And we all know that's above the the kidney, and we'll talk about the medulla or the cortex of the adrenal glands. So this is in the cortex is always the outside, medulla is always on the inside. Valuable in short-term treatment of many disorders. So if you had, let's say you had allergic rhinitis that was severe, and you're literally your sinus membranes were completely swollen, and you couldn't breathe out of your upper respiratory tract, and you had to breathe through your mouth. It was very, very uncomfortable. Using short duration would be great. Or if you had some kind of major inflammatory process that was hindering your activity. In short term, they're great. Remember, with these, you have to ramp them up, and then you have to ramp them down. You can't stay on these for extended periods of time, because if you are taking artificial glucocorticoids, your body's going to stop producing them because the feedback loop's telling it you already have enough. It'll stop producing them. All right. Valuable in short-term treatment of many disorders. Long-term use has significant undesirable results. And if you've ever, been to LA Fitness or Gold's Gym or whatever, you've probably seen some of these People who you suspect might be taking steroids, they can have some major, major long-term effects. Right? Anti-inflammatory effects are a stabilization of the vascular system by decreasing capillary permeability. These are some of the things that, wanted effects of these. Reduction of leukocyte and mast cells at the site, thus reducing release of histamines and prostaglandins. Blocks the immune response, prednisone. So these would be, you do anti-inflammatory effects if you know that this inflammatory process, even though it's your body's trying to fix the problem, we realize, well, this might cause deleterious effects, so we are going to chemically stop that in the short term. I'm not saying that modern medicine doesn't know more than the human body about fixing itself. I'm just saying in this situation, it might be advantageous. Long-term use has side effects. All right, atrophy of lymphoid tissue and reduction number of white blood cells. All right. Can lead to increased risk of infection and decreased immune response. All right, if we start shutting down the white blood cells, all right, we're not going to be able to have the immune response. That can be detrimental. All right, but if you're on, let's say you have a bone marrow transplant or something, and we're giving you these to diminish your immune system, we want to monitor that so we don't diminish it too much, because then you can be overcome by infection of something that shouldn't have been a problem. All right, catabolic effects are osteoporosis, muscle wasting, thinning, and breakdown of skin. I can't think of what's this called? Something syndrome. We get hunchback. It'll come up here. Delayed healing, retention of sodium and water leads to Cushing syndrome. That's it. Leading to high blood pressure and edema. All right, it should be used on an acute basis for short durations. Periodic breaks in use for extended period of time. So these people, if they're on immune suppressant drugs for a very specific reason, we have to take short breaks, ramp them up and down. And we want to make sure that we don't, I don't want to say confuse the adrenal gland. All right. Dosage should be tapered off gradually so that the body's natural hormone secretion can increase to normal levels. All right. So, I'm sure that we probably have all heard of rice. So I just kind of put in here rice, rest, ice, compression, and elevation. All right. The other thing they're really starting to well, not starting, it's been going on for years, but used to say, rest completely, but we want to actually increase whatever kind of motion we want gradually. We don't want someone to atrophy and lay in bed and not use the joint. We want the joint to move. Because remember, too, if your joint has cartilage, the only way it can get nutrients is through compression. We have to get that synovial fluid into that cartilage. It's the only way that those fibroblasts and the cartilage chondrocytes and chondroblasts can get nutrition is through compression of that joint. All right. So the healing process, I have some videos in there. Your book talks a little bit about it. There's some diagrams in there, but if you just want to maybe watch the videos or jump on Google search Khan Academy. Remember, there's so much out there now. When I went to graduate school, I started in 99 or whatever, there was not a lot of this stuff. So a lot of this stuff I had to learn on my own through textbooks or whatever. But you guys can jump on, just literally put in a Google search or, DuckDuckGo or whatever you want to use and plug it in there. This stuff should be coming right up for you. All right. Blood clot formed after injury to promote tissue repair, seals off the area. All right. Granulation tissue is highly vascular. We're going to bring that in there. We got to remember, we're going to anastomosis through these blood vessels. We're going to bring in a whole bunch of blood to supply the area. Because remember, we're going through mitotic division very, very rapidly because we're in the repair process. Right? So we're going to bring in the outside healthy area in to repair the area, and it's going to be highly vascular. And can be The repair is happening very, very rapidly. So it's going to be very, very red, swollen. And this can damage relatively easily, re-damage very, very easily. Okay, and there's just showing you the whole process. The cavity is filled with epithelial cells undergoing mitosis. It's going to bring everything from the outside in. Fibroblast. Remember, blast is always an immature cell, very, very rapidly dividing. Um, yeah, blasts are going to be going in, filling in the area with reparatory structures. Growth factors are released in the area by macrophages, and angiogenesis starts to take place. And that just kind of reminds me when I had a titanium implant put for one of my back molars. They literally, I thought it was the coolest thing, they literally drew blood. They separated the growth factors of the blood. They put it in the tissue when they did the implants. Fascinating that they did all that stuff. All right, factors that promote healing. And these, should be common sense to you. Youth, all right, good nutrition, protein, vitamins A and C, all right, components of collagen and things like that. So these are factors that would change your prognosis or the ability to heal, right? And please don't ever discount nutrition. A lot of people are huge into nutrition, healthy living, whole foods, non-processed foods, because remember, whatever you eat is either going to heal you or harm you. So you want to eat stuff that's nutritious. Remember, all these things you're eating have to be broken down by your digestive system, brought to your liver by the hepatic portal system. Your liver has to take all these components and make amino acids and make all the enzymes, make the white blood cells, make all the stuff for the healing process, collagen, clotting factors, and things like that. So if you're consuming toxins or if you're, eating genetically modified food that's full of Roundup and pesticides and everything, you're really going to start affecting the lining of the digestive tract and opening up those gap junctions in there and letting all of these chemicals, pesticides into your digestive system and into your body, right? So like I said, your digestive system is outside your body. We want to make sure that we're eating nutritious things. We don't want any of these chemicals or whatever getting inside your body. We shouldn't be consuming them anyway, but we want that to pass them out through the sigmoid colon whenever possible, whenever it's appropriate. So adequate hemoglobin, we need effective circulation, all right? So if you are non-compliant diabetic and you're destroying your capillary beds and you're not getting circulation to your distal extremities or whatever, or any of your organs for that matter, you're not going to heal. And you know that diabetics heal very, very slowly or not at all, right? Clean, undisturbed wounds, all right, factors that are going to delay your healing. Advanced age reduces rates of mitotic division, poor nutrition and dehydration, anemia, right? Red blood cells. You can't get enough red blood cells. You're not bringing oxygen to the tissues. You're not running the Krebs cycle. These metabolically, these cells can't heal themselves. They can't. Number one, they can't keep up with basic basal metabolic rates, and then they can't even repair if they're damaged. Circulatory problems, presence of other conditions or complications such as diabetes or cancer. Comorbidities, right? Diabetes, I know we're in pathophysiology right now, but I can't even stress the number of elevated cases of diabetes, pre-diabetics, just from terrible food choices, right? We're not nutrition, so I'm not going to spend a lot of time on that. The irritation of wound bleeding or excessive mobility. We said if somebody is going through rest, ice, compression, elevation, we also want them to do some mobility, but not insane mobility, just some basic mobility to get the joint or the tissue area moving. We want to get the lymphatic system flushing things out. We want to get fluid out of the vein. We want to get that fluid circulating, because remember, 60 or 70% of your blood right now, as we speak or you're watching this, is in your veins. Right? You want to get that moving around. Infection, foreign material, insulin deficit. And remember too, in case I forgot, insulin, we may have all learned that insulin's there to bring glucose into the cell, yada, yada, yada. But all right, so the real deal is insulin is a transporter for many, many, many factors to get them inside your cell. So remember, inside your cell, you should only, basically anything that has theoretically no charge, it's lipid, or there's certain things that can get in and out of the cell very, very easily. If it's very large, or it carries a heavy charge to it, it can't get in. You need insulin to walk it through. Chemotherapy, prolonged use of glucocorticoids can affect your healing. All right, and then remember, I mentioned before, complications of healing by scar formation. Scar formation is a reparative process if something doesn't have enough stem cells in the area to reproduce, and scar tissue is never going to function like normal parenchyma. It just won't, especially in myocardium, brain, obviously, kidney, or liver. All right, and myocardia, kidney, and liver, these are organs, you may not think about this, but these don't ever rest. They're going 365 days a year, 200 or 24 hours a day with no breaks. They never stop. They're very, very highly functioning tissues. Contracture, all right. So we have scar tissue. If you have scar tissue around some kind of a lumen, or you see scar tissue in your digestive tract. And if you kind of remember when you dissected your cats, or even if you're looking at some of the 3B models in school or whatever, your digestive tract was very much interlacing. If you have damage there, or scar tissue, can go around the lumen and contract it, or it can cause these things to stick together. If a lot of irritation, you can get a fistula, which is disastrous too. All right, so contracture, scar tissue tends to shrink with time, shortening and pulling or restricting surrounding areas. All right, and like I said, examples are stenosis of tubes or ducts. So scar tissue around the fallopian tube can shut that off. Scar tissue around the urethra, ureter, can shut those lumens down. Shut those lumens down, and you get nephrophoros, or hydronephritis in the kidney that can cause complete kidney damage or shutdown. So these things are things to think about or consider. All right, there's some scar tissue. We'll see some keloid scar tissue coming up. Scar formation. I think I want to get into the rule of nines. I'll give you a question of that on your exam. So this would be for burn patients. They kind of break down the body into 9% different areas. So it would be 9, 18, 27%, depending, contingent upon the area. Or if it's really, really small area, it would be like 4.5%. So there's going to be some derivative of 9. Adhesions can be bands of scar tissue joining two surfaces that are normally separated. Common sites are looped the intestinal areas, all right, between pleural membranes. So that could be pericardium, your the fluid around your lungs. So remember, if you get scar tissue in there, pleuritis, so inflammation of that pleural cavity. And the patient who had this, every time they breathe, right, patient actually had cancer of the lining. Every time this person breathed, it was extremely painful, constant pain, could barely sleep. Remember, your lungs never rest, heart never rests. So every time your heart beats, you're breathing, your irritation of that can be extremely, extremely painful. All right, these adhesions will restrict or prevent normal motion of the structures, and eventually cause distortion and twisting of the tubulus. So just kind of remember, if you have scar tissue it is locking things into place. And as they move or as food goes through your digestive system, it's moving constantly, and it can get very distorted because you don't have that free flexibility. So burns can be thermal, non-thermal, can be chemical, electrical, maybe mild or life-threatening. It really depends on how deep it is. There's a rule of nines, and there's like, used to be first degree, second degree, third degree burns, and now they're kind of moving towards like partial, full depth burns, and there's different nomenclature for this at this juncture. So burns cause an acute inflammatory response and release of chemical mediators, results in a major fluid shift, edema, and decreased blood volume. So as you burn, all right, your body's going to set up an inflammatory process to repair it. Now remember, think about this, all of your plasma, depending on how large the rule of nines is, what percentage of your body surface is burned or how deep it is, all of that fluid is going to be leaving your capillary beds. All right. So if they ever ask you, what's the major cause of death from a burn? And you're going to think, well, infection, right? Because you're burning the tissue, microbes can get in there. But literally, depending on what you read, the number one cause of death of the burn is dehydration. All right. You're burning, number one, all that fluid in your inside your cells and the extracellular fluid is gone. Then your capillary beds are going to release fluid to the area for the inflammatory process. So you're losing tremendous amounts of fluid. Severity depends on the cause of the burn, and the temperature, duration of contact, as well as the extent of burn surface and the site of the injury. And electrical burns can be terrible too, because, I shouldn't say, but your the fluid in your body is it's not distilled water, so it has ions in it, and they will conduct an electrical charge. So if you get electrocuted, remember that the electrical charge is running through every fluid inside your body. All right, and if you if you grab on it and get electrocuted, sometimes all of your muscles will contract. So even though you want to walk away, you can't, because that electrical charge is causing your muscles to contract. You can't move. All right, thickness of the skin is a large factor, especially with the young and elderly. All right, so the young have a much more fluid in their body. Their skin is relatively can be relatively thin, or they have a lot of fluid in their skin. And elderly have very, very thin skin. All right, there's no subcutaneous fat. So if they get burnt, they're burning right into the basement membrane immediately. Not good. So burn classifications: depth of skin damage and percentage of body surface area involved. Partial thickness burns, formerly known as first degree burns, involve the epidermis and part of the dermis. All right, so these are just your mild sunburn or mild scald. Say you spill hot water on yourself. As long as it isn't going into the deeper layers of skin or your basement membrane, usually heal without scar formation. Just think of sunburn or like a mild, let's say you jumped in the shower and hot water was on, you scalded your back or whatever. That will heal, be painful for a day or two, but it will heal. Deep partial thickness burns, formerly second degree burns, involve destruction of the epidermis, part of the dermis. Okay, so there's your area, what's going on there, and then the full thickness burns are going to be all the way down. So these literally will burn. These surprisingly don't hurt after, because you literally burned all the dendritic cells. All right, so they're not painful initially. You have to keep that patient from dehydrating and keep Pseudomonas off of it in the hospital setting. But they'll start being painful when those nerve cells start going back. That can be very painful. For full thickness, third degree burns, wound areas coagulated or charred, and therefore is hard and dry on the surface. Sometimes initially painless due to cutaneous nerve damage, but becomes more painful as surrounding areas suffer inflammation. This requires skin grafting because there's no adjacent cells for production of new skin. Remember we said with the wound before, the healthier cells in the area go through mitotic division, they grow in. But with this, you burned out the whole area, all right? So there's nothing to regenerate. It's kind of like when you burn down the rainforest, all right, in South America. You burned everything down. There's nothing to even reseed it or regrow the area. There's classification of burn depth. Right. And then rule of 9. So I think there's a video on it. So just kind of be familiar with the rule of 9s. It just kind of is a way of presenting the percentage of body that is burnt. Right? So complication could be severe shock, dehydration, kidney damage, right, and death. So please realize too, when you're burning all this skin. I know it sounds terrible, or it makes me cringe thinking about it. Sometimes all of these elements can get into the capillary bed, right? And they go to the kidneys. Remember, your kidney is going to flush out your blood, flushes out literally like 25% of your blood fluid continuously between the two kidneys. And a lot of these things can start plugging up the glomerulus. That if you remember, the glomerulus is where your afferent and efferent blood vessels go in, and we produce a filtrate there at the filtration system. A lot of these things that shouldn't be in your blood, a lot of these damaged components that get back into your capillary bed can start plugging up the glomerulus, causing some major kidney damage. All right, respiratory problems, inhalation of carbon monoxide, depending on what you're, if you're in a fire or whatever. And remember that carbon monoxide has a greater affinity to hemoglobin. And once you get one attaching to hemoglobin, even more keep attaching even quicker. And these carbon monoxide will not let go. It binds so much deeper than oxygen. So a lot of carbon monoxide poisoning. It takes up all the seats on the bus. There's no attachment sites for oxygen on the hemoglobin, so you can't oxygenate your tissues, can cause death. Exposure to cyanide. Right. High levels of oxygen are administered in an observation for respiratory impairments. Hot air, steam, these can actually destroy your mucosal membrane or damage the trachea, bronchi, or even the alveoli of the lungs, can cause some major problem. All right, infection, concern with burn patients. So opportunistic bacteria and fungus are waiting to invade these areas because you've just wiped out your first and second line of defense. You literally wiped out your mucosal membrane and your mechanical barrier. So Pseudomonas is the number one usually. This thing can grow on anything. It doesn't even, it can grows on sponges, mops, fixtures, whatever, and it loves burn victims. Staph aureus, Klebsiella, Candida, that would be an opportunistic infection. Okay, so that should be it. I don't even know how long that took. It seemed like an hour or so. So I'm going to convert this, upload it onto YouTube, and then I'll embed the video until I can get this whole WebEx things fixed.